Welcome. So everyone, thank you so much for joining us this evening. My name is Kasia Capisciolto, and I'm the Director of Compassionate Community Care. This series is to focus on protecting seniors. And so tonight we're going to share with you what you need to know to prevent elder abuse. And so this is a very important topic, and it's very dear to my heart, especially because I have elderly parents and step parents. And seeing what they endure and go through on, a weekly to monthly basis within their own respective communities has come to light some of these areas that we're going to share with you today. It's very important takeaway messages tonight. We're going to be sharing with you a lot of information, a lot of thoughtful resources, well thought out and planned so that you get the most out of these sessions. And just so you know, our community, it's called Compassionate Community Care, CCC for short. It is a registered charity comprised of healthcare professionals and volunteers who support vulnerable persons and their families during times of illness and crises. We at CCC believe that all human life has equal dignity and that every person deserves to be treated with respect and compassion while receiving the care they need and deserve. Whether you're facing a chronic condition, disability, or end-of-life situation, we're here to help. And so some of the services that we offer, and we can assist you with we can help you find the answers to questions about end-of-life concerns and find the educational support resources that you deserve. And so oftentimes we have people that will call our helpline. The number is listed here on the screen, 1-855-675-8749. And this is an amazing resource. And I say this, not to speak, too drastically, but it actually has become a very important pivotal mark in our country as a resource for people across the board. We get calls every day, and these can be calls that are very simple and short, direct informational type direct calls, or they can be longer and elaborate and more complex that take weeks to even months to resolve. And we ultimately are here to help you and support you with any decisions and discussions of end-of-life issues, elder abuse issues, your care and prevention of, assisted suicide and euthanasia. So if you prefer to contact us, though, on our non-helpline phone number, you can call us at our office. And these lines are also available anytime. They're 519-439-6445. And so this is the helpline, especially in what we're doing on the helpline side. And I just want to bring this to light because sometimes people don't realize it, but a little business card like this, we have, sorry, I don't think you can see it because it's blurring out, but we have a little quick business card that we share, and this ultimately has the same information that you see on the top right of the screen. And all it is we have magnets, we have business cards, and some people will call us with this information and just say, I just got your card, or I got your information from a board or bulletin, and I don't know why I'm calling, but something told me to call you. And sometimes it's a person who feels very sad, alone, depressed, and they want someone to listen and simply provide an outlet, counseling, a discussion, just an open ear to hear. And that's ultimately what we're here for. But ultimately, you too find that there are cases where people feel like they're being pressured, and they may feel like they're coerced, perhaps, choosing things that are not helpful for them, or maybe not allowed certain treatments or not being able to access certain treatments. So we provide that advocacy for them as well. We also enable conflict resolution between families and friends if there's interests that are being taken advantage of, for example, or there's a conflict of interest. We partake in that discussion if they require that as well. We provide education, so seminars like tonight and the series that we are starting with the Elder Abuse Prevention series tonight was actually the first of 3 sessions that we are going to host over the next few weeks. We provide also we support regarding to issues related to euthanasia and assisted suicide. So if someone feels that they have no choice and no alternative, but they want to commit assisted suicide, we speak to them and speak through that and actually talk to them and realize what is at the base of that issue and what is actually pulling them or coercing them or making them feel pressured to have to choose that. And oftentimes we find there are so many ways that you can actually move around that and away from it and actually help people live well naturally until they die. Training programs. We offered a wide variety of training programs, and myself and another very pivotal member and organizer who started with us very soon after we launched these programs, there's so many people that are building on this community. So we provide training programs, and we're inviting new people to join us in our trainings as well, and guides to help people to visit within our communities. So this you're going to see in the coming months as well. So ultimately, our goal is to build compassionate community care communities of dedicated members, leaders, and volunteers. So we invite you tonight to kind of think a little bit about what is loneliness, as loneliness has affected a number of people. Show of hands, I'm sure. Some people have been lonely over the last 2 to 3 years, perhaps. Yes. Okay, so I see that. And this is important because this brought to light many things, especially over COVID. As COVID went through Canada, obviously and internationally, we saw that loneliness looked differently for different people. So myself, I have 4 young children, ages 5, 4, 2, and 1. And I had 2 children during COVID. And, sometimes we felt even lonely. We felt detached and removed and isolated from other people and people we care about. But what we found is very important is what's happening around us. And really, it's nice to know that there were communities that were being built up, but there were also some that were falling apart. And so what we did is we looked at this study. We did a study at the end of COVID. We surveyed over 500 Canadians, and we provide a detailed summary and detailed report about this. This is actually going to be launched this coming week, next Thursday, in a week from today, May 18th. At our offices in London, but you're welcome to join us if you're interested in the results and the findings of that study. But it's ultimately an impact of seeing the impact of COVID on seniors and how the pandemic related to people and how they related to it. And as a thank you to those of you, if any of you have participated in that survey, we're inviting you personally to join us. You can do it in person or online, and you can register it in advance, and I'll send the link as well in the chat. But it is a great way to meet other people who are partaking in that. It's another way of getting the seniors in community together and actually sharing, time together and just creating memories, but also getting to know people and expand your connections. Some of the facts that we found from the Honoring Our Seniors survey is that seniors found that the last few years were quite isolating. And sadly, many felt abandoned or cut off from their communities, their faith centers, their loved ones, and their friends. And those who said they were able to deal well, remained positive, and did not experience depression or feelings of despair, remained active. And this is a very interesting trend that we saw, that there was 3 significant groups. Those people who fared better were often very busy, they had lifestyles, they had connections, and regularly met with, throughout COVID, with their family loved ones regularly. But sadly, there was a lot of people that felt, detached, isolated, and simply depressed oftentimes too. The third group was a smaller group, and they ultimately felt that as long as they had one person in their closer circles that they could cling to, or a spouse or a family member, someone they were in direct contact with, maybe even a pet or their faith, actually helped make them be able to get through that period. But what this means is ultimately is that we can do better, and we can, as a community, work better to unpack some of that trauma that happened. And oftentimes for many, it was abuse. So this is a little schematic and infographic for what we found in the studies. And more of this will be shared with everyone, whoever wants to join us next Thursday, May the 18th, at our office, or you can join us online from 4 to 5 as well. We'll be sharing this. There's also going to be great giveaway prizes and some gifts that we're going to share with people. So we'd love to have you and join us for that as well. And so from this survey, we ultimately found the need to create a resource on elder abuse, because we saw through the survey there were cases of abuse. There were people who felt neglected and institutionally neglected systematically. Some people felt financially that they were being abused. Some people felt that they were taken care of, not taken care of properly within their medical centers. And so we found the need to, first of all, share this information as a form of report, which we're doing next week. Also, we wanted to compile a great resource, and this is a handy little tool that we'll share with you as well after tonight's segment, and it'll be published on our website as well, and it'll be a free downloadable resource, and we can print and send or actually share copies with you, hard copies as well. And this is just outlining some of the forms of elder abuse, which we'll talk a little bit about today, and I'll let the speakers take over there when they speak about that. But ultimately, it's a great guide and a handy tool for anyone who wants to learn about more about what is actually elder abuse, and where they can find more information and support and help. So finally, I just want to mention this really quickly before we start and jump into tonight's speakers. We have this upcoming event following today with our 2 wonderful speakers. We're going to have another event, part of the series. It's on Thursday, May the 25th. We encourage all of you to join us. Our speaker and guest and expert, his name is Sue Scher. He's an experienced health, human rights, and constitutional rights lawyer. He's going to be talking about what you need to look out for in the modern family, especially when it comes to legal, financial, and family relations, especially when you're talking about human rights and elder abuse. So this is it's a daytime event. So it'll be from 12 to 1:30 on the Thursday. And it's also on Zoom and it'll be recorded for all of you to be able to refer back to. And I'll share those links as well to register. So tonight, I'm very excited to debut our first speaker of the night, and that is Mark. Mark Baluyut, thank you so much for joining us. Mark is an experienced registered nurse. He will speak on the clinical and practical standards of care. He'll be sharing tips that seniors and their loved ones should be aware of in order to protect against elder abuse. When a patient is admitted to the hospital, you can sometimes hear the word or term failure to cope or worse. What does that mean? Are they being neglected, and what went wrong? How can we prevent this from happening? So without ado, I'm very excited to thank Mark for joining us this evening, and I'll ask him to introduce and unmute himself. Thank you, Mark.
Thanks, Kathy. Thanks for that lovely introduction. Hi, everybody. My name is Mark Baluyut. I'm a family man. I've been married for about 6 years now. I have 2 kids, a baby girl at 3 and a son at 1 year old. My daughter actually just had her welcome to kindergarten today, so it's been very exciting for us today. I studied at McMaster University. I got my degree in 2011, and I've been a clinical nurse at St. Joseph's Hospital for 11 years. So I've been a bedside nurse for quite some time. Now, enough about me. Let's jump right into the topic. And I'll be talking about elder abuse and other problems. So some of the signs and symptoms that you'll be able to see with elder abuse are sores or injuries, vague or implausible reasons for injury, not seeking the care for their injury, being unkempt or unclean, which is this is the sign that we see mostly when people come in with failure to cope. Same with malnutrition and weight loss, dehydration. If they're afraid of somebody, they're just wincing when the person comes around, or they're very fearful when the individual is around. Financial fraud, exploitation, and sexual abuse. We'll be talking about 2 types of abuse. The physical abuse, which is an act of violence that may result in pain, injury, or impairment, or any disease. And the other may not be as direct, but is neglect, is the failure to provide the goods and services necessary for functioning or to avoid harm. Elder abuse, it can be seen by the individual not seeing a doctor or healthcare provider. If there are any wounds, that they are quite smelly or dirty, and the person has not received any medical care. The injuries that are most common that are seen with elder abuse are bruises, pressure sores, and fractures, and I'll be going those into more detail. So abrasions, they are superficial injuries, which involve the outer layer of the skin. It's caused by the movement of skin over rough surfaces, and it's both evident in physical abuse and neglect. Sometimes, depending on the integrity of the skin of the individual, sometimes in hospital, we have seen abrasions even just caused by blankets, by pulling blankets possibly too fast, and it can cause certain abrasions. And that's also based on maybe the type of medication they're on. But I do see with the elderly that their skin is a lot thinner, which can cause some of that if people aren't gentle when it comes to just bedding or removing clothing. Next, we'll be talking about bruising. A bruise is when blood vessels rupture and blood vessels escape into the surrounding tissue. This may suggest the cause of the injury. And the most common location for non-accidental injuries are the face and the neck. The next point would be burns. These result from tissue that is exposed higher than 50 degrees Celsius, categorized by 1st degree, 2nd degree, 3rd degree, and 4th degree burns. An individual with 65 have double the national death due to burns. It triples at 75 and it quadruples at 85 years old. Fractures. Fractures occur when an external force greater than the strength of the bone is applied. Older people are more susceptible as a result of bone disease or injury. Common sites are hip and wrist. Elderly people are at risk for spontaneous fractures. Now, unfortunately, the most common that I have seen in our clinical setting are hip fractures, and their special type of care is needed when turning them in bed and all that. And if you're not educated on how to properly turn an individual if they're immobile in bed, it can actually cause more harm. Then we go into lacerations. These are caused by sharp objects characterized by full thickness splitting of the skin, and common physical abuse. It can be common physical abuse, but can also occur with neglect. Now, the next one, pressure sores. That's a really big one in our clinical setting, which is an inadequate blood supply to maintain proper circulation to tissue. And a standard of care is pretty much the prevention. Unfortunately, with pressure sores, we can see them anywhere when patients are admitted either from homes, from nursing homes, when patients just aren't turned enough. That's causing that, or if they're incontinent and are not changed in a timely manner, or which we'll talk about later, can also be caused by malnutrition, and especially when the individual is quite small. The bony parts of the body will cause a lot of the pressure sores as well. And the pressure sores, they pretty much start just with a tiny red spot on the skin. It might look like nothing, but that is a stage 1 sore, which can turn into a stage 2, which is pretty much broken skin. And if that becomes untreated, or the patient isn't turned or changed in a timely manner, it turns into a stage 3, and it goes to your second layer of skin, and eventually into the fatty tissue and the muscles. And that's when the individual should have been admitted at this point, because there's a lot of wound care that needs to be involved almost once, if twice a day, that needs to be done. And it has to be a very aseptic, clean technique. And there are deep tissue injuries as well, where it actually starts from the inside of the body and works its way up. And the most other common is the unstageable ulcer. So if you look at it, it's pretty much just black, which is just dead skin cells, and you're unable to stage it. You have no idea how long, how bad this ulcer has been. So this individual could have been just lying in this one position or sitting for hours and hours a day. And in a hospital, our goal is that we actually have to turn them once every hour. So we use pillow support, we turn them, sometimes slings, depending what we need, but we try to take care of them. And the number one, and in hospitals, there's a huge policy that actually has to do with pressure sores and bed sores. And we try to make sure that it never actually happens. And if there is one, it gets immediately reported. Another one is restraints. There's abuse or neglect when using restraints. If a person is restrained in a non-critical situation, when we have to restrain people, it's usually for their safety and our safety. However, restraining may not always be the best situation, because their behavior can worsen when they are restrained. And sometimes when they have calmed down, or we see that it would be better to release the restraint, we do see that the individual actually cooperates much better at that point. It is required to constantly monitor a patient that is restrained. Even just 2 restraints, we always got to make sure we at least check on them every hour, because people could exit the bed that way and injure themselves. And there is very, very important policies that we also have to follow when it comes to restraining individuals. We try to refrain from restraining individuals. That's the last resort if we have to do it. Next sign of abuse would be a skin tear. The sites other than the arms or legs, or having multiple tears and abrasions, should raise suspicion. And skin tears can heal without any scarring. Another big one is malnutrition, which is a big marker of neglect. Sometimes, however, though, the individual may not recognize the cultural food preferences and may not want to eat certain foods. The other issue is that there may not be enough staff to feed individuals if they're not able to feed themselves, and improper feeding techniques. We see malnutrition on the unit quite often. We see it in the blood work, which then results in osteoporosis, which then causes people, which opens them up to fractures more. their skin integrity goes. So malnutrition is a very big factor. And if people don't have the proper nutrition at home, everything just spirals down. And just have to make sure the skin goes, everything goes at that point. With that, dehydration is also a very big part, which also is quite a big factor when people are admitted, especially with failure to cope. They're not eating, they're not drinking. You can see it in their skin. Their skin is very dry, which makes the skin integrity again. So everything connects when with all these points. Signs of dehydration are confusion and sleepiness. Other risk factors that contribute to dehydration are medications and decreased absorption. Another one is individuals with dementia. Unfortunately, these individuals with dementia do not recognize that they're being abused. They may not be able to report the abuse or talk about it, and sometimes they may not even be believed. And this all also starts again with the whole malnutrition. People get confused. You're not eating the proper foods, then there is no proper bowel movements. People become confused. Then with the dehydration, all of that again is all connected. And there's a large, unfortunately, with the amount of admits we have, the failure to cope and dementia have increased on my unit, at least. That's pretty much what we see a lot. We're not even surprised when we see a failure to cope come in anymore, unfortunately. The other one is self-neglect. This is accompanied by dementia and mental health problems. This makes victims more vulnerable, dependent on others, and abuse or neglect leads to depression, which in turn leads to self-neglect. Yes, with self-neglect, we see people come in. Usually, the diagnosis on the floor is failure to cope. Signs are people are very unkempt. They're not able to control their bowel movements, not able to feed themselves. And it is our goal to get them back to baseline as close as possible. But if that's not possible, or if there's family members who are not able to bring them back, or if the family member is not reviled, social work becomes involved, and they take care of how this discharge will continue. The goal is to have a safe discharge for a patient, pretty much. The next point is alcohol abuse. This affects about 5% of older individuals. This is more common in men than in women. And in the elderly, lower levels are needed to feel the ill effects of alcohol. One big unfortunate sign of abuse also is financial abuse. This happens to widowers in the 70s or 80s, living in the community, and they say it's the crime of the 21st century. The type that I've seen on our unit usually occurs when people are elderly and we have a big home. And you see people coming in that they haven't seen in a very long time. Sometimes kids, grandkids, you see the patient's children, adult children, arguing on the unit about who gets the house. And it's estranged children that show up out of nowhere. And that's usually a type that we see, the usual financial abuse that we would see on the unit. And that brings me to the end, and I'll introduce you guys to my colleague, Kasia.
Perfect. And may I just ask a quick question before we continue with Kasia?
Sure.
We had a question in the chat. What is failure to cope, if you were to define that?
Oh, sure. It's so when an individual that comes in that is unable to take care of themselves at home. So then it pretty much, instead of being a medical admission, it starts off as a social admission. But due to, like, once we start to assess the patient, we do start to see some medical issues. Usually it's like blood work that seems off, but sometimes it's very, it's very, you can see it right away that if somebody is not being taken care of, just the way that they are, like their skin is, how do you behave, you can just see that. But usually failure to cope is usually a social admission where an individual is not able to take care of themselves at home. And the goal is to get them home or to a facility so that they can have a proper, that's so that they are properly taken care of. That's the goal. Yeah.
Perfect. Thank you so much, Mark. And thank
No
you for
problem.
your warm introduction to Kasia. We're going to segue into Kasia. And if anyone else has questions, you can personally message or direct message us on the chat form box, or we can answer your questions at the end as well. So if you wanted to hold on to those. I'm going to move right through and jump into our next presenter and guest speaker and expert, Kasia Capisciolto. Sorry if I mispronounced that.
No worries.
Sorry, if you can correct me, that's great. So we have Kasia with us tonight as well, and she is a mother. She's a concerned advocate for the elderly and the vulnerable, especially, and you'll hear that very strongly through her presentation. We thank her for this. She will share her experience working at a facility that was in need of assistance from the government in order to provide proper care for its residents. Kasia will be giving you practical, very tangible and important considerations. And her talk will feature and center around the needs of seniors, especially residents, when evaluating their care options. So this is a very important talk. We're going to record as well, of course, this whole segment. So if you want to come back to this segment, you can always review it later. So her topic and title is What Do Seniors Need to Watch Out For? And without much ado, thank you, Kasia, and warm welcome to you. Thank you.
Thank you, Kathy, for your very lovely introduction, and Mark for your very informative presentation as well. And good evening, everyone. So thank you for allowing me to speak today on such an important and prevalent issue. So as Kathy already said, my name is Kasia Capisciolto, and I am a wife and mother to 3 wonderful children. And I've also been a nurse for 11 years. And I started my nursing journey working with elderly residents in long-term care. And then I transitioned into endoscopy, and I worked as an IV nurse in the recovery room. And overall, I'm just passionate about sharing that empathetic and selfless quality of care for all patients. And I truly believe that nursing is a calling and the work of the heart, where you're genuinely kind and considerate, professional, yet present to others, willing to lend an ear and to listen. And just showing dignity and respect to others is all part of that healing process. So it's super important to me and in my eyes. And so when I graduated as an RPN, a registered practical nurse, I was ready to give it my all. And I got a job working, my first one, working at a long-term care home near my house where I used to live. And I guess I'm going to paint a picture of my day, like a typical day of a RPN in a long-term care home. I was a casual nurse at the time because I was also studying to be an RN. And so I worked as a casual nurse. And this long-term care facility had 237 beds. That's how many residents there were on 4 floors. Each floor had about 70 residents, except the first floor had about 25. And so myself and another RPN would be scheduled to work on a floor, and we were in charge of 35 residents per shift. And as a side note, in Ontario, there is no legislated minimum staffing ratio of how many nursing home staff there is to residents. So as long as there is 1 RN on duty at all times, you're pretty much okay with the protocol. And as a casual nurse, I was often scheduled on varying floors. I was on 2nd floor, 3rd floor, 4th, and I often had problems locating residents that I didn't yet know. And my residents would often mix and mingle with the other residents on the same floor. And I would just spend a long time identifying who my patients were, since I was so unfamiliar with everyone and I was unfamiliar with everyone's medication routine. I just found it so difficult to organize my day so that I had ample time to assess residents, to give them medication, provide treatments, chat with residents, to document. Yeah, my days just felt very rushed and disjointed. As an example, some residents would sometimes go downstairs to the dining hall, and for their 3 meals, breakfast, lunch, and dinner. And I would often have to, like, I didn't know where they were, so I had to run downstairs, leave all my other residents upstairs, run downstairs, just to find my resident already eating. And this was, for example, a diabetic patient, and I didn't yet check their blood sugars yet. I didn't give them any insulin, and they were already eating their meals. Obviously, they're free to do whatever they want. It's just that it's just the volume of patients that I had, and the amount of medications each person had was just so much to organize. And after my shifts, I would just spend about an hour or even more sometimes to just document everything that I have done during the day. And I personally felt like I was put in a situation where I couldn't feasibly practice safely and do all my assessments prior to giving medications as required. The facility employed me to do a specific job, and I felt that I just couldn't fulfill that role without putting my license in jeopardy. And so, just as you can see, under even normal circumstances, no emergencies or anything like that, I still fell behind in my work. And I still felt like I didn't do proper assessments. I still felt that I had a lack of time to accomplish all of my duties. And my whole role just revolved around medication, just giving out medication. As soon as I was done breakfast medication, it was time to start the lunch medication. So that was like my sole kind of role there. And so after all that, I guess, stress, and I had work on this, my schooling on the side, I had to leave this job, but more out of fear than anything, because I didn't feel like I could do my job 100% on every shift. And if I felt those feelings, I'm sure other nurses and staff felt that pressure too. Like, staff was already experiencing burnout, and this was back in 2012, 2013. So, like, as an example, there was an inspection report done in March 2013, back when I was working at that long-term care. And I'm sure there's similar situations across other long-term care home facilities where an inspector observed that a resident was lying in bed during the day in their night clothes, incontinent, not having been changed or cleaned, and a strong urine odor was noted coming from the resident. So this was in that inspection report. And as a result, the long-term care home failed to comply with the continence and bowel movement protocol, ensuring that residents who use continence care products have sufficient changes throughout the day to remain clean, dry, and comfortable. So that's just an example to show you that, burnout already existed, understaffing already existed back way before COVID. And so let's fast forward to 2020. It's the peak of COVID. And the government now has taken over management of my former long-term care home. I didn't work there at the time during COVID, but the long-term care home felt like they were just sinking and they needed help. So they reached out to the government. The government came and took over. And the pandemic, honestly, it just amplified these issues greatly and brought them out into the light. They already existed, but now everybody was hearing about it. It was brought forth through the news and articles on TV. And I'm sure some of you, and maybe have heard, a well-known scandal was when the Canadian Armed Forces were called in to assist 5 long-term care homes in the GTA. And their report that they put together was quite shocking. They alleged that there was a lot of ill-trained, burnt out, and in some cases neglectful staff who were trying to just cope with the growing care needs of the elderly residents there. And so during COVID, this is peak COVID, another inspection report from my former nursing home. This report was from June 2020. It showed that, for example, employees were observed to be wearing black garbage bags over their clothing, and they were double masking, and they were washing their gloves in between patients instead of disposing of soiled gloves, and doing proper hand hygiene. Like, I'm sure Mark can agree, we've been taught for eons that hand hygiene and proper, washing of hands, using hand sanitizer. That's like the pillar of infection control. And everything just flew out the window, right? And it seemed like the staff was trying to protect themselves, I guess, and rightly so. I mean, this was the best maybe way they knew how, but they were trying to protect themselves, but in a way they failed to protect the most vulnerable. And I'm not going to be hesitant, and I'm going to say that these staff members, I think, would be considered super spreaders of infection in this case, because not changing your gloves in between tasks and in between patients, that's obviously unheard of. It was unheard of. Now we see so much of it. So all in all, this could have been a lack of policy put into place at the nursing homes, or just the overcrowded nature of long-term care homes, I guess. Another inspector reported that COVID positive residents would be put into the same room as COVID negative residents. So they were residing together. They were no isolation techniques were being used at the time. And so yeah, I just want to continue on and bring into light a few statistics. There was a report from the Canadian, CIHI, the Canadian Institute for Health Information, sorry. The Canadian Institute for Health Information, they came out with a report about the impact of COVID in long-term care homes in the first 6 months. So they concluded that in the first 6 months of COVID, long-term care residents had fewer physician visits, okay? In April 2020, about 24% less physician visits. May 2020, about 20% less physician visits. And also 30% less transfers to hospital for the treatment of chronic conditions like UTI, delirium, pneumonia, COPD. So in those cases, long-term care homes would transfer the patient to a hospital for more acute care, but they weren't doing that. And in every long-term care home policy, there's a protocol for prevention of abuse. And in my former nursing home, the policy clearly stated that neglect is the failure to provide the care and assistance required for the health, safety, and well-being of a resident. And this includes action or inaction. And some examples would be withholding of services. So just like Mark mentioned, an older adult not being able to see a doctor, if you're preventing someone from seeing a doctor, that is considered neglect. You're withholding needed services. So that was prevalent. And another point that they made in the report was that something else that we saw, like Kathy mentioned, was social isolation. And this is where an older adult is not allowed to see their family, friends, neighbors, and it is a form of psychological abuse, elder abuse. Once again, in any long-term care home policy, you have, they define emotional abuse is any threatening, insulting, intimidating, or humiliating gestures, actions, behavior, or remarks, including imposed social isolation, infantilization, right? So it's in their policy. And these older adults are not children, right? They reside in long-term care because they require help with activities of daily living. They need help with feeding, changing, hygiene, right? And we're not there to give them advice on what hobby they should do or can you go outside or not. Like, they're not children. My question is, why then were institutional policies made to implement this abuse in long-term care homes as a means to combat COVID? So they imposed social isolation to combat COVID. Like, it should be obviously the last thing to consider because it's a form of psychological abuse. And then finally, the report ends off saying that of those residents that were socially isolated, 36% were assessed to having moderate to severe depression. So that's quite a large number of people. And moving on, just in nursing homes, usually meal times are a form of socialization. And during COVID, people were no longer doing that. They were eating meals in their rooms. Meal trays were brought in by staff, and usually the residents were ready to go, and they're ready to eat. And a report here stated that an inspector noted that a resident had waited up to 50 minutes until somebody came back to help feed them, right? So like Mark mentioned, this could be a form of malnutrition, I guess, right? Like you're just sitting there ready to eat, but you can't because you need help to eat. And this could be insulting and humiliating to somebody to just be looking at this food for an hour before somebody comes and helps me. And it's also dangerous because those people that cannot feed themselves are at risk of choking and they need that assistance, right? So that was also noted in a report. Just the first wave of the pandemic placed a heavy burden on the frontline staff and in healthcare, as well as those in housekeeping. So 28,000 staff were infected during this time, which meant low staff numbers due to absences. And because of low staff, we have a report here from the Ministry of Long-Term Care in my old former nursing home. They noted that some residents had not been bathed at minimum twice a week. So that was their minimum. And some people were not even bathed one time a week. Some people had to wait a few weeks until they got the bathing that they wanted, right? A shower or a bath, whatever they wanted. And there's actually an article about that where a son of a resident from my former long-term care home, he was on a hunger strike in front of the long-term care home. He was chained to a tree, and he just wanted to bring awareness to the conditions inside that nursing home because he got information from his mother that she wasn't being looked after properly, that she hadn't been bathed well in over 5 weeks. This is him alleging that. And so this was another thing that was in the news, bringing it to light. And another report, I'm going to give you an example of how low housekeeping staff numbers can affect the nursing home. So there was a report from June 2020 from my former nursing home, and an inspector came and they toured the home, and they toured the home areas as well as the linen storage areas. And it was observed that 20 resident beds did not even have a bedspread or a blanket. Some beds only had top sheets. Others only had a blanket, but no top sheets. And the linen room, when they inspected that, they had no towels, no face cloths, no pillowcases, sheets, blankets. And a PSW even confirmed with the inspector that there was no reusable incontinent bed pads to use. That same day, they interviewed a resident, and the resident said that the resident was actually observed to be in bed with only a top sheet, so no blanket, just like a little thin top sheet. And the resident stated that they had to ask for a blanket every night because they were cold, and they were never given a bedspread. So this is a form of neglect. It could be inactive neglect, not intentional, but the elderly were not given proper care that they deserved, right? I'm sure most of us still had blankets and bedspreads during COVID time, and we were nice and warm, but our older adults in long-term care, they were not guaranteed that basic need. And that's important to note. Another institutional abuse that I want to touch on are the effects of medication on the elderly. And I just want to kind of preface this, but if you or your loved one take medication, whatever it may be, I want you to be proactive and ask your doctor or your nurse at the long-term care home or your doctor's office, what is this medication for? Why am I taking it? can you please show me a list of current medications that my loved one is on right now? If you are the power of attorney, ask for a current list of medications and see how often they're taking certain medications. So I'm going to actually touch on a few of these things. Antipsychotic drugs. So for example, Cipralex, Risperidol, Seroquel, they're sometimes used in nursing homes to manage behavioral symptoms, especially with residents with dementia, but they are not recommended. There's an organization called Choosing Wisely Canada, and they suggest that it's not a first choice in treating dementia symptoms because of their strong side effects. And even the black box warnings for elderly patients with dementia indicate that there's an increased risk of serious side effects like pneumonia, heart attack, stroke, death. And there was an analysis of the 6 provinces during COVID, and they found that antipsychotics were prescribed much more during the first wave of COVID. And the 2 provinces were Ontario and British Columbia that had the highest percentage of antipsychotics being prescribed. So 34% of all residents in Ontario are on an antipsychotic medication, and 44% in British Columbia are on an antipsychotic medication of all residents in the province. So that's something worth noting, right? Is this the best practice? Feel free to ask your doctor, right? And then another thing that I often see is prescribing benzodiazepines. Some benzodiazepines, some examples are like Ativan, clonazepam, midazolam. Like they are usually prescribed to treat anxiety and like panic attacks, alcohol withdrawals, for anesthesia, right? If you go for a colonoscopy, you might be getting midazolam mixed with another drug. So these are usually in the long-term care setting, these are usually prescribed to elderly residents so that they are calmer, especially when it's like their day to shower or to bathe. They give them like lorazepam just to calm them down so that the caretaker, the PSW, can just do her job quickly and go on to the next person. So prescribing this medication could seem as if it's done for a neutral purpose to aid the caretaker, and then in turn, you're able to provide hygiene to the resident. However, there are much less invasive things that could be done first. And in the end, benzodiazepines are shown in studies to harm older adults because older adults metabolize drugs slower. And so when you're giving a benzodiazepine to an older adult, they're at an increased risk of cognitive impairments, delirium, falls, and things like that. And then even the Canadian Army, when they were in those long-term care homes, they made their report, and they alleged to seeing the drugging of residents whom the staff claimed were being difficult or agitated. But then when the Army people went to see the residents, the residents only said that they were scared and feeling alone, like they were in jail. So they were not agitated, and sedation was not required. That was what they said in the report. So it's still being used today. My husband's family member, she's on a benzodiazepine for showers today, and we're actually looking into it right now. So just got to be active and look out for these things. So as well, improper use of meds. So over medication and under medication, these are 2 important things. They can lead to neglect very, very quickly. There could be a slippery slope here, especially for older adults. And it's important to just know the side effects to be looking out for. And so one of the things I wanted to touch on are using sleeping aids for older adults, Tylenol PM, even Gravol and Benadryl. They're used for allergies and nausea and things like that, but off-label, they're also used as a sleeping aid. And if they are used regularly, like every day for long periods of time, it can cause, actually there's studies that say that they can worsen dementia or even cause dementia. So if they are used regularly and for a long period of time. Same thing with Tylenol. You know, it's a very effective medication when we have our fevers or whatnot, but regular use of Tylenol, we have to know that it is toxic to the liver and it will eventually destroy it, right? So in my former long-term care home, there was an inspection report. And I'm just going to give you an example here. There was a resident who had fever, and consistently for 7 days, they were given Tylenol, but the doctor's orders were to just give 3,200 milligrams max for a 24-hour period. But in those 7 days that they were giving the Tylenol, every single day they were consistently going over the recommended dosage that the doctor said. So they failed to follow doctor's orders, and they consistently over-medicated that resident. And by the way, all these reports and these inspections, they're readily available online for public viewing. You can just type in any kind of nursing home, and if you want to look up complaints or reports, it's all online. So it's important to be proactive and look into this stuff. NSAIDs as well, things like Advil, ibuprofen, naproxen, if taken, once again, regularly for a long period of time, it will eventually eat away at your stomach lining. It will affect your kidneys. And, you know, once you have one problem, you might have to start taking other medication to mitigate those problems, right? So now you have to take a pill to help your stomach. And it's like a snowball effect. And then lastly, another drug just to be vigilant about are statins. There's some very interesting studies that have come out in 2021. Research presented by the Society of Nuclear Medicine and Molecular Imaging. And they indicate that taking lipophilic statins, so your statins like Lipitor, you might have heard of, simvastatin, fluvastatin, anti-cholesterol drugs that lower your cholesterol levels. So if taken, these drugs more than double a person's risks of developing dementia compared to those that do not take statins. And honestly, I'm not surprised with these results because our brains love fats. They love cholesterol. They run on fats and cholesterol, and we need those. We need cholesterol in our bodies for our bodies to run smoothly. And if we consistently lower those cholesterol levels, it will eventually take a toll on our brains. And so I'm not saying to stop your statins. I'm just saying do your due diligence, do some research, talk to your doctor, and investigate this further, especially if you or your loved one are taking statins. And you might be seeing like some cognitive impairment starting. Maybe it's worth questioning. So all these drugs that are being prescribed, we have to put our detective hats on and ask, why is my loved one, for example, taking this medication? Is it for a diagnosis that they have and this medication is for that? Or is it like a sudden onset of something? There have been numerous reports from my long-term care home. The building itself was very decrepit and old. I even saw a few mice a few times, and there was an inspection report that noted you know, a buildup of dust and mildew in some rooms, in some shower rooms. There was a black substance resembling black mold that was present. And as we know, sometimes mold can have not only a negative effect on our health and well-being, but also on our mental state. So there had been some cases where people moved into homes with black mold and then they became depressed, right? So if our nursing homes are not up to standard, if there is black mold on the walls or on the baseboards, is my loved one actually depressed because of some sort of a situation, or is it because of the type of room that they are in? And so, like I said, put your detective hat on, be very vigilant, open your eyes when you go into a nursing home. If you have a complaint, don't be afraid to ask a nurse or to tell a nurse, or to go directly to the director of care, and they should be the ones reaching out to you. Lastly, I just want to, on the last slide here, I just want to say to be an advocate for older adults, question policies, look at some records, and if you also are suspicious of housekeeping or maintenance frequency, bring that up with your director of care at the nursing home. And lastly, if you really need some help, you don't know where to start, reach out to Compassionate Community Care. They're there for you 24/7. You can just pick up the phone, ask a question. Like, I've noticed this in my nursing home. I filed a complaint, but nobody has come back to me. What should I do next? And they will help you. So this is a very wonderful organization, and hopefully you will reach out to them in need. So thank you very much for listening to my presentation. And thank you, Kathy, for hosting this webinar.
Thank you so much, Kasia, and also Mark, for your very insightful, informative, and I think very thought-provoking, thoughtful messages and special information that you gave us today. So thank you both for taking the time to speak with us and to inform all of us about what's happening. I know we're going to segue shortly into our Q&A session. So I encourage ladies, gentlemen, if you'd like to ask a question, you can raise your hand. There is a raise hand function under, I think it's apps or more. So you can add that, or you can just simply chat, put it in the chat as well. Or you can unmute yourself. But just before we do that, I'm just going to summarize a little bit on some follow-up items that I wanted to share with you all today. And since we'll be, after our Q&A, we'll be finishing off, we wanted to ensure that you're equipped with the upcoming events and know what opportunities we have for you to join us in other sessions as well, which will be just as informative. This is just a quick note here for the links to the articles that Kasia mentioned in her talk. You don't have to scramble them up, but I can send this to you. So for each of you who are with us tonight, I can actually forward these links and this information to you. So you'll all have the links, you'll have the information, the stats, and everything she refers to, benzodiazepines, the use of, even Tylenol, impact of COVID and long-term care facilities, that's all available, and I can forward that to you in a subsequent email. So I'll do that, okay? And following them to the same, note here and train of thought, we often ask ourselves, what is the solution? So as Kasia nicely, thank you for mentioning that we are here for you and to help you. Compassionate Community Care has a helpline, and it's not just ourselves, it's with myself and people like Alex Schadenberg, who has been a key pivotal figure in this work, and this is special calling to advise people and to consult with people, and others as well behind the scenes that you may not maybe know the names necessarily, but there's many people that make up who we are and what we do. And it could be from a legal perspective. We've helped people who have found that their loved ones were passively euthanized, and that was as close as last year in the summer. And we're working with them to help encourage them for that. We found people who were not able to access services and procedures that they needed to get over pain and proper pain management. And so we help them and advocate for them in that way as well. People who need alternative medicine therapies, for example, we will refer to those people and those practitioners as well for those individuals. So there's so many things, mental health issues. There's just countless number of people that have helped all these people in this great work that we do. And so this slide here, I just want to mention this. What is the solution ultimately? Because people who face elder abuse may actually come to call us. And what we find is the solution is ultimately what is summarized so nicely by Dr. Kevin Vast in his Guide to Loneliness. He states that if we are truly to be awakened, we must awaken to each other's needs, including the need for community and interpersonal connections. We must ask ourselves what we can do to stem the tide of loneliness. Now, oftentimes we see people at the tail end of elder abuse when they've already felt abused. And how do we prevent that? Well, we'll talk about that next. But the main thing is, if you're not in communication, you're not interpersonally connected with one another, you won't be privy to that information. You may not even be able to hear from a person that they're being abused, and then you may not be able to stop or prevent it. When we hear of these stories that Kasia mentioned and Mark is talking about the cases and the types of abuse, some of those instances we don't even hear about until someone actually speaks up. And it's often because someone asks them how they're doing. It's so simple, but this interconnectedness is pivotal, and it's an important part of our work. And why we actually share what we do is, and I'll show you in the next slide, how this all comes together. Because as we grow in awareness of our lonely community members, reaching out to them, we will help to lighten their load. And this is in so many ways. It's the ways of helping in a psychological way, mental health. It's physical, it's spiritual, and it's also emotional. So there's so many facets to this. And there's real ways that you can help. So for each of you that want to know this, there's ways that you're already helping, I'm sure, because you're visiting with people, you're connected to many people in many various groups. But if you're not, this is a great opportunity and invitation to partake in this important work so that you can access people, so you are ensuring that more people have the support that they need, and ultimately to prevent any types of abuse if they are actually occurring. One way to do so is to visit the elderly in their homes. This is a picture on the right of my son. My youngest is 1 year old. His name is Tobias. And in this picture, you can see it slightly, but I didn't want to include too many people. There's a group of seniors that we visited just before Easter. We went as a group of mothers, and we partook in this great activity, and we made paper lilies, Easter lilies, with a group of seniors locally in Peel. And the kids loved it. They loved the attention. The elders loved it because they were able to talk about their children, their grandchildren. There was many people who referred to Tobias that he looks like their grandchildren, or one of their grandchildren. And it was just a fun time. So if you haven't thought of this at all, or you were doing this or want to return to doing this, visiting the elderly is a fantastic way to be practically doing the work. And I encourage you all to do it, regardless of time. And so we encourage you to engage in social interaction. Ultimately, if people feel isolated, they are more likely to remain cut off from people, not responsive. So by simply involving them, asking them, would you like to join me today to go to the library, go to a walk outside? It's beautiful now. I have a wonderful neighbor just down the road who my kids love, and his name is Klaus, like Santa. And he liked going not too far from here. There's a beautiful pub, apparently, that's a brewery, and they make local beer. I've never heard of them. And he likes going there for soup. He says they have great soup. And so this week I'm going to go by and we'll say, why don't we go for soup together? Because we like soup too. And, it's just something so simple, but this is what we used to do. And Alex, when he shares this in our sessions, when we train, he says this often, that his kids grew up going across the street to, Mrs. Mary's house, and they would partake in her life. They would check on her every day. They would see how she's doing. She would garden. They would come out. They would share times. And, when she passed away, ultimately, a few years later down the line, his children were very impacted by it, and they all attended the funeral, and they saw all these beautiful children there, and they said, well, who were these kids? Well, these were the people who lived closest to her, and they were involved in her life. And some of her own children noticed that these other kids were very involved in her life and said, wow, I didn't even know that, I heard of your kids, I've never seen them, and yet they were so close to her, right? So you realize that you have a pivotal role in all of this. Some opportunities are to make a tea, so a seniors tea, a coffee event. You can create one in your faith community. You can create one in your group, in your wherever you reside in those communities. Asking around, see if those are already available. There's a very active parish here in Peel and Mississauga that we realized every week that they have events, right? And it's wonderful. It's beautiful to see. They have lunches for the seniors. They have, Father's Day events, Mother's Day. They have, just wonderful events, festivals all the time. And you can create those groups. One other opportunity is to create card games, taking people to community functions, senior events, faith community events, and special interest ideas. Is there a sporting event that someone wants to partake in? Also a great idea. You can go for a walk, like I said. Mobility is important, and just simply developing friendships in your communities is so important for this. And visiting retirement residents. Oftentimes we went for that visit, like you can see with little Tobias, right that same day. One of the ladies in the guests that were there partaking in the activity asked us to come over and visit with her immediately after that event. So we went, and me and another friend and her 2 kids and my 4 kids all went in and actually met with this woman, and it was just beautiful. So sharing that important bonding time, and also just that influence of wanting to be there, being with people, is very important here. We also encourage you to create compassionate community care chapters. And these are chapters that are already sprouting out across Canada, which is exciting news. We've got well over 15 now sprouting. There's about, multiple in Ontario. There's some throughout Canada. And what we would love to see is every, city or township or county have a compassionate community care center wherein they have dedicated volunteers that they could partake in and visit with their people in their community. And what's wonderful is that you are reminding people by being present with them, by simply being there, being with them, you are telling them that they're valued, their life matters, and that they're appreciated. And you would be surprised how much that means to people. It makes the world of a difference. And so this ultimately is a way to take action, proactive action, and very practical action to protect against the widening of MAID. As you know, we do have many cases of MAID continuing in Canada. Just recently, we found that over 20% more cases of MAID were reported in 2022, and the stats are still coming. But Canada, in terms of MAID and medical assisted dying or euthanasia, is one of the fastest growing, more rapidly growing countries since legalization. We've surpassed numbers in other jurisdictions that have had it legalized for over 20 years. So if you can imagine how impactful simply visiting with people in their moments of vulnerability is, you have no idea. So I really encourage you, and I ask you to consider this seriously. If you hesitate, how do I start visiting, or what do I do? How does that look like? Well, we will provide the tools for you. We give you the resources and we give you the education. It's very simple. It's a simple training we offer, and it's myself and Alex Schattenberg. We co-host these sessions together. We offer these every 2 months. And, there's really, you can watch them online after the fact, or you can join us live. And it's very interactive. We role play, we talk, and we cover questions. And it's the Being With My Story Visiting program. And what it does is it helps people have a resource. You have a book, we send it to you. It's free of charge. You get a training manual as well that prepares you for the day of the training. And you simply learn online over 2 nights or 2 days. It's usually about 4 hours total, split up into sessions. And you gain the confidence to journey with those who are suffering, socially isolated, sick, or dying. And you help to renew their hope and purpose in life. And it's ultimately empowering you to empower others. And the book you receive, it's a fully printed book resource. You can take as many copies as you wish. They're ready, they're printed for you, and there's no cost. We ask if you're encouraged to, by all means, please feel free to donate. It is a great resource. And what you do is you ask them their story. And so you interview the person that you meet with and you say, let me hear about your life. What were your, what was your childhood like? Who were your siblings? Who were your parents? What did they do? What did you grow up doing? What was your career? And they go into that beautiful background reminiscent therapy. And this ultimately helps them want to live, and actually is more life affirming for them. Sorry, Erica, did you want to unmute yourself, please?
How do you train? How do you sign up for this training online?
Great question. That's my next slide. So on June 6th and 7th, from 7 to 9 p.m., we are hosting our next training, which is available. And I'm going to post these links to register right now in the chat for you. And I'm going to just make sure that it's going to everyone in the meeting. Perfect. And this is our next training with Alex. And what's wonderful about this is it's free. Okay, the resources are free, the books are free. So you could even interview your own parents if you still have them. And you'll be astonished. I have heard where people have said that they regretted not interviewing their own family members because they've since passed away, or they've incurred, dementia and other things that have, progressed so quickly that they weren't able to capture this. So I definitely encourage you to check out this training. We do have sessions that were recorded, available online. There's, it's limitless to the opportunities that you can do in your own groups and your own communities to do this. Another thing I'm just going to add here is that we have another training that we offer. It's a 1 day, which is only 1 night. And what it is called the patient advocacy training, in which you gain the skills and confidence to be an advocate in the healthcare system. So much like we heard from Kasia and Mark today, that there's certain struggles that people don't know how to advocate for themselves. And this is a very common phenomenon. We hear it on the helpline side very often. And what do? Well, who's the power of attorney? Who's their advocate? Do they have a power of attorney? Is there a power of living will agreement? If there isn't, then let's put one in place if the person is competent. And if you don't know about that, or you're have questions, you can actually receive one from EPC, and you can order one from them. It's, I think, $10 plus tax, and they can ship it to you or they can email it to you. And it's a very handy tool for someone who has questions about this. And this training here is very practical. It's only a one night, which is a 2-hour session. And I also post a link here. The next one that's coming up is one night. It's June 13th. And what it does is it shares with you all the tools, the practical things that you need to know to how to be an advocate. And you don't have to have background in nursing or medical backgrounds. You can be a layperson and simply learning how to advocate for your loved ones, for yourselves, and for the people closest to you and in the community. You can become an actual advocate. And we've had cases where people have done their training with us, and then they've gone ahead and trained and been advocates for others in their community, and they love it. If you have questions about advocacy, to first do our session and learn about it, because you may realize that you're not the right candidate for advocacy at all, for a person that you know, or just in general, because it takes a certain type of communicating that's required in advocacy. And there's also people where we screen people ourselves internally. When people ask for advocates, we ensure that we screen our candidates thoroughly. We also ask that if any of you want to become advocates in the community, that you complete a police criminal background check and a police vulnerable sector check. These are two forms of review of your background in which the police are involved. There is a fee, but if you want to be thoroughly checked and recommended, we ask that you do that. And we could even spot you the fee for that if you need it, because this is something often that comes up for people as the cost factor behind it. Yes, may I ask you to please mute Erica? Thank you.
What's the difference between a vulnerable sector check and a police check?
Sure. So that's a great question. Criminal background check is often required for volunteering at any organization, but when you're working in the ministry work, or if you're working with vulnerable persons, they ask you to do a vulnerable sector check, which is simply a second layer of screening and tool where they ask you more specific questions. They look at your full overview of your history and background, and they provide that in a record form for you. So you can submit that into a group or a training for like, say, for example, with our own advocacy group. So if you decided you wanted to be an advocate or a patient advocate community member with us, then you could complete that as well and partake in that on a wider community level. There are even some advocates, I'll mention this quickly, wherein they actually have phone call sessions, because often, as you know, from COVID, many doctor visits, medical appointments were done on the phone. And now we find there's this onslaught of people who are backed up because they haven't had a chance to visit with their doctor or meet with them. So they're actually completing these phone call meetings. And in those meetings, they're feeling vulnerable because maybe they have it's a person with a disability, or they have a communication issue. They're not assertive enough, and they want someone to be an advocate on their side. And all they want you to do is sit and listen and be able to be another voice for them in case they miss something or not able to speak up about their situation. So I hope that clarifies a little bit for you, Erica. Does that help?
So the vulnerable sector check is enough, or yeah, that's where I'm just confused a little bit.
Sure. So both would be asked of anyone who wants to continue to be a community advocate. And also we would ask if people are especially working in their own ministry, if you have a ministry part of your faith community, that you get both checks completed in Canada. Yes. Okay. And Byron, I'm sorry, did I answer your question as well? Okay, thank you. And then, so these are the two events that were happening. I just posted them. There's the June 6th training, which is June 6th and 7th. That's the first link. And then the June 13th is the next, which is the patient advocacy. And this is a slide I just want to share with this really quickly with all of you. So for those of you who are potentially interested in doing the My Story program and being a trained volunteer and a dedicated community member, these are some of the ladies who are partake in a group of women called the CWL, and they are the difference because they got out there and in the London area of Diocese of London, they got together and they made the difference because they went out and they met with people in their communities, the ladies there, and they spoke to them, they interviewed them, and we collected all these stories. Over 50 women collected stories, and they went out to meet with them and interviewed them. And this is a beautiful collection of stories. You may recognize some of these ladies. These are a wonderful group of women who happen to be related to my husband. That's his aunt right here, the lady in the middle, third one from the left. And she's very involved in that group. And, she did the story and we interviewed her as well. And she was so happy to be partaking this. And, they're stunning testimonies of life, love, family. And this is what you get to be part of when you do the training. You get out there and you visit in the community. And you have this sparkle, you know, the lady in the center, she's 95 years old. She has these beautiful nuggets of wisdom she shared with us about how to be in life and be successful. Both women shared about their stories. And these are just fantastic, delightful, encouraging. They're poignant, they're beautiful, and they're lovely ladies. And they're actually, you can be ladies in your own community, I'm sure, right? Like you could put any one of the people you know, their faces here on the screen, and they would just be so happy and thrilled to be part of this. And I ask you too that you are going to capture now essentially family histories. So there is this factor of CWL, but there's also potentially other groups too that you might be part of. You know, it could be a knitting club, it could be a book club, and you can create a living legacy from their stories from those groups. So this can be applicable across the wide-ranging parts of this. And so one thing I'll ask is, if you can, do encourage you to join us next week on Thursday, May 18th. We're having this special invitation for people who participated in our event. And it is a wonderful opportunity to meet with us in person, but also simply that you can actually learn about the study, learn what effects it had. And I'm sending you an invitation here in the chat as well. Feel free to join it. You can register online or you can attend in person as well. And that's a thank you event. And this is the story of what we did. And we published these wonderful stories of the 50 ladies. And it's so important to share with people who have given so much. And these are great copies that you can actually get from us, and you can order and we can send it to you. It becomes a living legacy, and you can actually pass this on. I'll show you a copy right here. Actually, they're really nice. And you can publish this and have the opportunity to simply have people to see what it is, what a person's life meant to them. And you know, you can make it a smaller version or a copy, but ultimately this is a beautiful way to capture someone's history and their life story. And yes, you're right, absolutely. It's a very important tool to have, an opportunity. And so I'm just going to invite you, finally thing is for the next talk that we have, we're going to be hosting, it's May 25th. That's the last link that I shared in the chat. And that's with Hugh Scherer. He is a human rights lawyer and advocate and a constitutional lawyer as well, relating to health matters. So you're very welcome to join us for that, all of you. We hope you can come back for that. And finally, if you need to reach us, we're available 24 hours a day, 7 days a week. This is our helpline phone number. We receive calls every day. They're meaningful. People are impacted positively. Lives have been saved, of course, and continue to do this important work. And so we thank you all for joining us. I'm going to open up the floor now for some questions. And if you need to reach us, our contact information is on the screen. We do appreciate these sessions are free. We can encourage people to join so there's no cost. But if you are finding that this is impactful and important for you, we'd love to have your support in any form. And if you'd like to donate, we do have a charity number, so we will register your donation and issue a tax receipt, and you'll receive that at the end, early 2024 for any donations made this year. So definitely stay involved, stay in touch with us, and please do reach out to us, and we look forward to hearing from you all. And I'll open up the room now for everyone, whoever has any questions. Any questions from the group? So how far, someone's asking, Lori, how would I go about obtaining business cards and magnets with helpline for CW ladies? Yes, so for that question, I will actually reach out to you personally, and you can order them as we're getting more done right now. So I can ship those out to you, and I'll make sure I'll send that to you, okay? So thank you for that. There was a note in the chat just a couple of slides earlier. I think this was directed to Kasia. The Ministry of Health and Long-Term Care issued directives to restrict or limit visitors in long-term care facilities during COVID. It was well into late 2020 when families were allowed back in to be with their loved ones. So it's just a general comment. Yeah. Okay. Perfect. Thank you. And there was a question as well about restraints. Sometimes people find that this is very difficult, and we actually at CCC don't recommend the use of restraints at all. And I noted that Mark said that as well. So he paralleled that same idea. It is the last worst case scenario and example, I guess, of what can go very wrong. And oftentimes we don't encourage it. So we don't support the use of restraints, but we do see, when Mark mentioned it, there are certain cases that are very exceptional. One thing I wanted to note here, because there was a question about this pressure sores. If Mark, you can maybe unmute yourself. Why are pressure sores so imperative to prevent? And why is the standard of care of prevention?
It's very important to prevent because it's not just a wound, which ends if it is untreated, it can become infected, and not just locally. You can become septic, and that is actually very life-threatening to that point. And the standard of care is pretty much prevention. The number one goal is to make sure that a bed sore does not occur. And the best way of doing that is proper incontinent care and turning the patient and not having them lay or sit in the same position for multiple hours, pretty much. Yeah.
Yeah, thank you so much. We had a patient, thank you, Mark. We had a patient actually who contacted us, and this was a very, very hard case because they developed sepsis after a pressure sore, and it got to be a full-blown, full body infection and progressed very rapidly. So we encourage any of you that are aware of this. I did not know this before I worked with CCC, that pressure sores are a way that make people very vulnerable to death ultimately, and it's a septic shock scenario. So it's very difficult, and it's very something that you have to hold as a high standard to make sure that your loved ones are being turned regularly and moved around. Yes, Mr. Sampson, may you please?
Yes, especially with someone who has diabetes. They're
Yes.
very bad.
Yes, yes. That's right. You're right. Absolutely. Thank you for the feedback. Yes. There was also, yes.
Sorry. Kathy, I would like to say thank you very much. These sessions are so informative. And tonight especially, I didn't realize about the seniors suffering cold nights, no blankets, bed sheets. It's heartbreaking. So you guys do a wonderful job. I love following you on your program.
Thank you so much.
Thank you.
Thank you very much. Thank you for your support. There was one question I wanted to mention here, that there was during COVID was such a stark contrast to what normally has happened in the past for many patients and especially elderly people. A woman had contacted us through COVID because before COVID, she was actually partaking in her mother's care very closely. She would come to see her mother in her nursing home 3 times a day. She would feed her, making sure she got her meals. And this woman, her mother had dementia. And so it was very difficult for the staff to take care of her properly and feed her. And so she would take the time, her daughter would come and see her every day, 3 times a day, and feed her. And this was good and it was successful. Unfortunately, though, COVID happened and they locked down this resident's home, this nursing home. And the mother was alone and she was not able to have these feedings from her daughter, and they would not allow her daughter to come in. And unfortunately, sadly, very tragically, this mother passed away 2 weeks later. So it's a horrible story, but we bring it, up because it is something that, God forbid, ever happens again. People need to be proactive and really intervene quickly and be involved in the care of their loved ones. And if anyone has any questions, please feel free to ask now, and we'll close off the session in a minute. So again, thank you all for joining us. It's a privilege and honor to be with you and to share Kasia and Mark with you. And I thank you both, Mark, Kasia, for joining us and sharing your insights. This is a good point. Someone's just mentioning I work in a retirement home and would love to share information. So definitely we can connect you to that and give you some of our resources. Jayan, thank you. And I hope everyone has a wonderful rest of your evening. Thank you again. We appreciate your support. And, take care and do stay in touch with us. So thank you all for joining us.